Hello and welcome to Head Injury Heroes, everybody. My name's Lady MJ Warrior and I am with Dr. Kester Ned, who is a neurologist all the way from Miami. Hello there, Dr. Ned. How are you today?
I'm doing just fine, and thank you for the opportunity to speak to
your
audience.
I can see your book in the background, which we're going to be having a little in-depth talk more about later, aren't we?
Okay, we will.
Yes. So would you like to tell us a little bit more about your 30-year journey of being a neurologist, please?
Well, thank you, and good morning again to your audience. So my journey as a neurologist started at an early age. I've always been interested in the nervous system. And when I started in college, I had the opportunity of working with a professor in biology, looking at animal behavior, how animals behave, and how they communicate and so forth. And that actually intensified my interest in both studying behavior from the brain perspective, what we call the mind-body relationships. And later on in medical school, some of my most favorite courses were in the neurosciences. That includes neuroanatomy. When I got accepted at the University of Miami to
the screen seems to have frozen. Hello?
Do my postgraduate work in neuroscience, I relative paucity of interest in this area. And so over the years, I've developed expertise in this field. And this has actually brought me to where I am today.
Excellent. Sorry, the technology froze a little bit there. So I hope we can still
Good.
Yes. Yeah. So can you please talk us a little bit through how you treat patients with traumatic brain injuries and concussions?
Well, first, in order to effectively treat a person with traumatic brain injury and a concussion, one must understand the nature of the disorder. And I'll start by saying it's the most complex disease of the most complex organ of the body. And so a thorough understanding of brain injury and what the patient would have gone through in the process of the injury and in the process of recovery is first necessary. Once there is an understanding, one could obviously develop treatment methods and approach to the patient. In our case, we believe in early intervention because what happens to the brain when it's injured, it's a very smart organ system in that it compensates. It makes up for the deficiencies that it would have experienced or suffer. And some of these compensatory mechanisms are actually not in the best interest of the patient and in the best interest of society at times. So those are the negative symptoms that persons experience after a concussion. And many of them are compensatory. So part of what we try to do is to first understand what are the signs and symptoms that relate to the direct effects of the injury, and what are the signs and symptoms that relates to the compensatory mechanisms that the brain, the body, and the world around us go through when there is such an injury. And therefore, an approach could be developed and designed for this. Now, another point is understanding the natural history of the injury and recovery process. In order to intervene, you must have a thorough understanding of this. In my early years of training, one of my professors always said to me, don't treat what you don't understand. And so part of the problems we have in the brain injury world is that many of our experts are actually treating something that they don't clearly understand. And that's why we're in the state we are today in evaluating and treating brain injury. And in fact, that's one of the reasons I wrote the book, is so that I could identify better tools and ways to analyze persons with brain injury that would eventually lead to effective treatment methodologies.
I think that is an incredible point there that you mentioned, is that medical professions are trying to treat diagnoses they don't actually understand themselves, and trying to relay that information back to patients. And
the real issue is that brain injury, because of its complexities, not only do we have trouble studying and understanding it, we have trouble comparing persons with brain injury in terms of clinical trials and studies, because each patient is different and the ability to classify them is difficult. And what we need is a multi-dimensional approach. Part of the problems we see with brain injury is that we approach it with 1 or 2 dimensions, and quite different from, say, a psychiatric patient or someone with a fracture. Brain injury, we have to look at it in terms of time, space, severity, types of signs and symptoms, the nature of the recovery, the stage of recovery, and certainly the impact that the society in general has on the person that's injured. Many of the treatment modalities that we use, we inappropriately apply them at times because we apply them at the wrong time or stage of the injury.
So may I just elaborate a little bit more on that point? So you mentioned there's different stages, and how would a doctor and or a patient detect and indicate, like, what time to implement each treatment?
First, as I earlier indicated, data collection is really critical. And the brain is a hierarchical system. It's organized. In my book, as it said, it's from head to tail. The most sophisticated part of the brain is at the top. And as you go further down, the least sophisticated parts of the brain. So in understanding just that simple concept, this allows us to essentially, from a physician's perspective and a neuropsychologist, or even some of the other therapists that are involved, we understand what levels of sophistication is required based on the degree of disruption or disorganization that occurs in the system. So looking at it from head to tail. So if you're looking at the most head structures, which are the most complex, that allows us to talk and feel emotions, and the functions that allows us to interact with society and have emotions. Now, if you think of a computer, the computer doesn't have emotions, but the computer could perform some very delicate functions. So we have these, what we call higher cortical functions. And when they get disrupted, they actually disrupt who we are and what we represents to others in the universe. Now, the lower brain functions, what we call the vital functions, those involves breathing and swallowing. And these are functions that automatic, we don't think about, they sort of reflex. When those are injured, they create a different set of problems, because what happens, the higher centers actually influence how they manifest and express themselves. And therefore, we have to clearly classify the nature of the injury. Based on the type of injury that we see, we could literally classify those injuries and understand prognostically the long-term effects in terms of severity and what would be the manifestations clinically. And once we're able to understand that, we could target treatments. So in the case of the lower brainstem or the lower brain activities that are vital, if your breathing is affected earlier on, then you obviously need to be on a ventilator to support you. In the higher centers, such as in the frontal lobe, that controls some of your filtering, your ability to filter and be appropriate in public. If that part of the brain is injured, you will still be able to breathe and walk and do many of these functions, but you may be inappropriate in the setting that you are. you may make inappropriate comments that others might find offensive, for example. So that would require a totally different type of intervention. We see a lot of times that people have trouble with integrating their ability to interact with the environment, and that also requires a different type of intervention.
You have an extraordinary mind, Dr. Ned. This is fascinating.
Thank you.
Yes, this is something that I feel our listeners are going to be blown away to hear. And I understand that you have over 250,000 patient encounters with traumatic brain injury, concussion sufferers. And what are the common factors and patterns between the patients?
Well, that is, again, you pointed out, my experience in seeing lots and lots of patients over the years has allowed me to see patients from when they come into the trauma center, the emergency room, or emergency department, through the intensive care unit, or when post-surgery, when they have certain interventions, through the regular hospital stay, into the rehab center, and what we call thereafter the post-acute service that patients may go through. That's for the most severe forms. Now, in the less severe forms, many of these patients are discharged home, and then we see them in the outpatient setting. So by us, in my experience, having the ability to see patients go through the different phases following an injury, that allows us to look at the different patterns that patients present with. Now, what's fascinating in my, again, referring to my book, there's a chapter, the chapter before the last, I wrote about the brain likes patterns. So after injury, the brain develops patterns, and part of what we've learned to do is to recognize the different patterns that the brain develops as it becomes disorganized during the process of recovery. So one of the important patterns, for example, is a disruption of body and brain cycles. A good example is sleep. The body has many, many cycles: energy cycles, sleep cycles, mood cycles, hormonal cycles. And whenever there is injury, these cycles become disrupted. What happens after there's disruption of those cycles? There is dysfunction. That's when the patient experiences symptoms. So for example, hunger and thirst occur in cycles. And there's a center in the brain called the satiety center that when that gets disrupted, we feel hungry at different times, or maybe there are times we can't stop ourselves from feeling hungry. And one of the challenges we see in patients with certain types of concussions or traumatic brain injury is weight gain or weight loss. Some people become anorexic, and others would actually gain significant amount of weight because they have no sense of feeling full or having an appetite. So these are some issues that often, these issues are often not paid attention to. And there are so many external factors that influence how that process works. Just understanding the brain operates much like a computer system. You have an input where we receive all of the information from the outside world: how we see, how we hear, how we feel, how we experience motion. Then the other part involves processing, like the central processing unit in a computer. So we process that information, and then we have an output, which would be a response. So what actually happens during injury is this simple analogy I give of how a computer works becomes disrupted. And part of our job as neuroscientists and others treating brain injury is to figure out where in this process injury disrupts. So if it disrupts the input, which with how we get sensory information about our environment, about people, about our experiences, then that causes significant problems. If it's in the processing of the information where we assimilate it and then we spit that information out as, from an output, then we see certain signs and symptoms. So part of our job in the evaluation and treatment of patients is to decide where in that process the brain is impaired.
Yes, definitely. There is a relationship between the brain and the computer, and I think that's a very good metaphor for people to think about how a computer can work. And for example, if you've got a lot of tabs open in your browser, then it crashes, and I feel like that's the same how the brain kind of crashes. Probably not as straightforward as that, but there's definitely that connection.
Well, in fact, I used in many of these illustrations about how the computer works. And clearly, one of the most common problems we see with persons with brain injury is an impairment in their processing ability. They can't, for example, in a conversation, they may not be able to keep up with multiple persons talking at the same time. Or, and I always use the illustration of looking at a movie. When you speed up the movie, you really can't, all of the frames that go by, you can't assimilate it with your brain. All right, you can't tell the storyline if the characters are moving too fast in this movie. And so this is actually what happens to a person with brain injury. In fact, one of my patients actually explained that to me once. He said, Dr. Ned, I feel like I'm looking at a movie sometimes that's going way too fast and I can't keep up with the frames. And again, some of these illustrations I learned from my patients in describing how they feel about their injury. So that is the issue that we see with the impairment in the processing ability.
Well, they say life is like a movie at times.
That's true.
It's only as simple as freeze frame in the moments and, you know, fast forward in the bits that you don't want to deal with, but such is life. So I'm going to ask a little bit more about brain hierarchical evaluation and treatment method, which I believe you created.
Yes. So when you look at all other species in the world and see how they've adapted their ability to function from the most simple cell to the most complex persons in the universe, you realize that there is a hierarchical system in the universe as far as living organisms. And even before we were born, that exist in our structural, anatomic, and physiological development. And I already alluded to having what we call the higher and the lower centers, the head to tail. You know, again, my book is titled Concussion, Traumatic Brain Injury from Head to Tail. Head being the most sophisticated part of the nervous system. Now, when you look from an anatomic and physiological standpoint, you think of the brain as quite sophisticated in the highest end. When you think, just take the visual cortex, the part of where you see things. Just one side of the visual cortex contains over 180 million nerve cells in order to experience, 180 million nerve cells, just for us to experience vision on one part of a visual field, to understand the form, the shape, movements, all of the characteristics that you would experience in sight. When I take a hammer, a reflex hammer, and I tap the knee of someone and you see the leg gets pushed forward, that's a simpler function. That's a lower function that comes from the spinal cord. It takes only 3 nerve cells to perform this act, okay? And again, that's a list of sophisticated. Now, the higher centers in the brain could influence how much that leg moves when you tap the knee, what we call the deep tendon reflex. So you see, the anatomic organization of the brain structurally is tied to how much function there is. And that hierarchical understanding in terms of brain injury allows us to be able to classify the degree of impairment based on where and at what level the brain is injured or disorganized. So the hierarchical organization of the brain allows us to understand where the brain is injured, how we predict the degree of recovery that we will see, and what treatment methodologies one could implement when there is injury. And that is, in my opinion, the most organized way to understand it. Now, in terms of clinical research, when I look at the literature in brain injury, it doesn't, most of those studies done on brain injury fail to take this type of hierarchical organization into consideration. And as such, in many cases, we draw the wrong conclusions. And certain therapies that might otherwise be effective, we find them not to be effective because we are applying them or the treatment modalities at a point in time or at a level where it would not apply. So clearly, part of the reasons I've put forth this concept of the brain hierarchical organization is to provide also for scientists a kind of research framework in terms of how we can understand the brain and better study. Because when you look at the amount of money we've spent on brain injury research, it's a lot. But yet we've come up with very few treatments to this. Just to think, I mean, the brain by itself contains well over 100 billion nerve cells and over 1,000 trillion connections. So to understand how complex these connections are and the tremendous power the brain has, any disruption of this type of organized system severely impairs our functional ability. The other point that I'd like to make on this is that through a process called neuroplasticity, the brain has a tremendous ability to reorganize itself despite its complexity. And so just understanding these concepts helps us come up with where we are and what we need to do to treat persons with brain injury.
That is mind-blowing is a simple way to say that. And may you help us understand a little bit more about neurotrauma?
Neurotrauma, when you think of neurotrauma, this is a very common condition that we fail to recognize. In the US here, in a person's lifetime, when you think about a lifetime, 1 in every 4 person would have experienced traumatic brain injury or concussion in their lifetime. And here in the US, about 3 million persons have been recorded on an annualized basis as having a concussion. Worldwide, there is about between 42 and 50 million persons. Studies done by the CDC, the Center for Disease Control in the United States, have shown that 88% of the times, persons with a concussion or traumatic brain injury go unrecognized, undiagnosed, and untreated. So that tells you more people in the world have this condition than we fully understand, and the impact of those, the traumatic conditions are quite significant. We don't realize it. When you look at we just, in my book, of course, I touched on the subject of persons that are incarcerated. Somewhere between 62 and 92% of persons incarcerated in prison or arrested have suffered a traumatic brain injury or concussion. And so when you look at what's happening in sports, what's happening in the world of interpersonal relationships and violence, this disorder is more common and it affects our behavior. Many times I see patients in my clinic that come to me with psychiatric diagnosis or physical problems, not realizing that what they're experiencing was the result of an injury that occurred maybe in early childhood or in their teenage years or even as an older person. And so this disorder is more common and it impacts on society in tremendous ways. I mean, we see people having trouble on the job, in studying, classroom settings, getting divorced, engaged in activities that would hurt others. And we sometimes fail to understand that the roots of that may be in the effects of trauma to the brain that might have occurred at the time that they didn't realize. And take, for example, you see individuals with phobias. When I see a patient, someone that comes to me that has a phobia, they're afraid of crowds, they're afraid of getting into a closed space. Many of these patients would have had a concussion. And because of the panic, the anxiety that they feel from not being able to handle the inputs into the nervous system, the multisensory problems, they become anxious. And so, for example, motion as an entity is perhaps one of the most significantly impacted sensory experiences that persons with brain injury experience. So we can't, persons with brain injury very often can negotiate motion in the environment. And so when the car is moving or when they're in a crowd, they go to a mall, an airport where lots of people are moving around, they get dizzy, they get double vision, headaches, they get tired and they want to leave. And so they develop phobias just from going into crowds or where there's lots of motion, and they tend to avoid things. So many of these psychiatric conditions and conditions that people experience, physical conditions, have a basis in a brain injury, but clinicians like myself, we often fail to ask the question, did you suffer a concussion? I mean, something as simple as falling from a swing or hitting your head on the edge of the pool and not thinking about it, or soccer ball or football or something like that might have caused an injury and you didn't pay attention to it. And you may get, one of the things we see is that many of the individuals that suffer these conditions, they actually get better to the point that they would say, I'm cured, I'm fine. But until they get exposed to a stressful event, such as something with excessive motion, they may not realize that vulnerability may express itself. And so when that occurs, by that time, they may have forgotten that they had a traumatic brain injury, not realizing that that condition existed. And that's why you see these so-called psychological and psychiatric manifestations.
I think that's a really great way to explain it. Excessive motion. That's definitely one way to think about it. And we was just you know, talking about some of the challenges. So how does this affect the recovery process?
A key point that in my treating my patients that I've realized is that early intervention and a clear understanding of the nature of the injury for the patient, the clinician, and others around the patient is important in aiding recovery. If we treat many of the physical offending symptoms early, the brain actually avoids compensating. These compensatory measures that the brain automatically take, like becoming anxious or developing things like OCD or panic attacks, these are compensatory symptoms and signs that occur because of the negative effects that the body feels or is reminded of as a result of an injury. But if we could first recognize those compensatory mechanisms and intervene early and help the patient understand why they're behaving in such a way, or why motion, for example, is so detrimental to their ability to function in society, then you could start the process of healing. One of the things we like to do in treating is to intervene early to avoid the patient from experiencing as much of the symptoms as they do experience. And so we use both pharmacologic and non-pharmacological interventions. By pharmacologic, I mean medications and non-pharmacologic, non-medication interventions. And yes, there are different views of points on this that some people say, well, let's not treat early with medications. Let's leave the brain alone and let it recover. There is some merits to that, but clearly Some patients, the physical and emotional symptoms are so overwhelming that you want to spare them from experiencing those. And so it's just like going under anesthesia, going to perform a major surgery and not having anesthesia. Imagine the reason why we put people under anesthesia during the surgical procedure is so that they don't remember those negative effects. And so people that experience these negative effects, take, for example, the soldiers that are returning from war, that they get the post-traumatic stress disorder, those negative experience cause them to behave in ways that they have no control. And so it's important in an early stage to be able to identify those circumstances and the behaviors attached to that and intervene. I find that when we do early intervention, early education of the patient, the doctor, the society, the other treating entities of the nature of injury, that we are more effective in the long-term outcomes of patients we treat with brain injury.
And I guess some people wouldn't have thought about the kind of symptoms that you mentioned. And I was just wondering what you would say to people that doubt or disbelieve sufferers with invisible disabilities, and could you help them understand the reality of the situation, please?
This is a major issue, and if I were to say in my life and in my experience that there is a tremendous need for advocacy, this is one of the areas. There's a lot of biases, and a lot of this comes from the fact that the legal system, when you look at a person with a spinal cord injury or fracture, you see something wrong. You see them in a wheelchair, but when you look at a person with a concussion or brain injury, they're walking and talking. So you think they should be fine, but they may be inappropriate, they may be fearful, they may have anxiety, panic, OCD, any of these symptoms, bipolar-like symptoms, and you think, oh my God, they have a mental health problem, let's put them in the institution. And so society as a whole actually treats persons with brain injury as second-class citizens because that injury is so invisible. And so it's clear in my mind that when you study the impact of traumatic brain injury and concussions on society, if we don't address those issues, we will see more and more ills in society that we're not able to resolve and treat. So it's critically important that there be a sense of education, and that goes from the school system. You're talking about in organizations, in groups that advocate for brain injury. Being able to articulate this one fact could make a significant difference. And also to legislators and policymakers. One of the things I've spent a lot of time, again, talking about in the book is to critically look at the medical institutions who treat brain injury. They spend more time on other disorders. I compare this to someone who has a stroke in the United States and around the world. We have so many protocols for stroke and for treatment of other neurological disease, and we don't have any. Just the fact that there are few trained doctors and therapists and others approaching and treating, being available for treatment of persons with brain injury. Just look at per capita, how many experts are available in the field is pathetic. This disorder by incidence and is occurring at, and prevalence is occurring at a much higher rate than a disorder such as stroke. Yet we spend more resources. When you think of the pharmaceutical industry, they spend lots and lots of dollars on other disorders, but compared to, say, persons with TBI, most of the insurance companies cover the services up to a certain point. So after the first month of rehabilitation in most countries, there is very little services available to persons with brain injury. And so as a society, we must get our legislators and the people who are responsible for allocating resources to this condition, we must get their attention. And again, people with brain injury can advocate for themselves because they're not in an emotional and cognitive state to be able to do this type of advocacy. So just like mental health disorders, these are disorders that are less recognized and covered financially in our society.
That is a fascinating point. Absolutely. Definitely listen to that one, especially even more. Think about that, because it could open people's mind a bit, and it could also save a lot of lives.
Absolutely.
So that's like the crucial part of it, isn't it?
We could make the world a better place if we take brain injury and we recognize it as an illness. Until the Afghanistan war, the US Army, the US military did not recognize traumatic brain injury and concussion as a signature of war. When you think about the sports world, it's only within the last 5 to 10 years that they've recognized concussion as a major cause of disruption. When you look at, for example, now this whole issue of dementing illnesses that we see, there's a condition called chronic traumatic encephalopathy that we see in persons who have repeated concussions to the head. This is a disorder that we have no cure for, no treatment. And it's occurring at a rate faster than we thought in the past. Once these concussions occur, it changes the entire physiology of the brain, and we see certain pathological conditions that now we know are the result of the effects of trauma. So yes, it's clear that we need to study this more.
And with your expertise and studying, would you say that you've found a fast recovery method that you've recorded? And if so, how was the patient being treated?
Well, let's say this. A lot of what we do in brain injury still needs to be researched in what we call double-blinded placebo-controlled trials, so we could understand the effectiveness. But I could tell you, just in my experience of seeing a large cohort of patients over the years, there are certain tools, there are certain do's and don'ts that I find effective. And one of them, my first one I always say, is early intervention. There's a whole concept up there that a lot of clinical professionals, some of my own colleagues, perpetuate, that we need to wait and see. Don't get involved, let the brain do its thing. I find that to be a fallacy, in the sense that I see more people suffering as a result of that approach than not having intervention. And again, that's why we don't have as much professionals. I mean, when you think about it, a child falls, hit their head, and the parents may or may not do something about it. You take them to the emergency department, and the doctors would say to you, they'll be fine. And yes, they'll be fine, but then that child now has attention deficit. They can't sit in class and focus. And of course, the parent is not thinking that that person had a concussion or TBI that was not paid attention to. But now we have to deal with medications and disruption to the family and self-esteem issues. And a lot of those translate into adult behavioral problems and coping on the job and in relationships and so forth. So yes, from a treatment perspective, my philosophy in introducing this methodology is, one, first, intervene early. Second, first, understand where you are in the continuum of the evaluation of the patient. So we're looking at the natural history, so you understand where you are, what level the brain is injured. Look at the impact of symptoms, whether or not those symptoms are producing compensatory findings that have negative outcome, and intervene. So I believe certainly there are different medications that could be used. There are different psychological and neuropsychological therapy, physical, occupational, speech, language therapy, music therapy, vestibular therapy, vision rehabilitation. There are many disciplines that we could use. Unfortunately, many of these have not been studied in research paradigms that allow us to draw the right conclusions and partly because we don't understand where we are and what methodology to apply at which time. So what I find in my own practice, I've learned this methodologies to come up with some process of how to apply a treatment modality at a particular time or stage in the recovery process. And to me, that's part of the winning strategy to treat and help people with brain injury.
And would you say that with recovery, there's differences with gender, age, background, or any other specifics?
Yes, and that, again, looking at this whole multidimensional approach to the evaluation and treatment of patients with brain injury, these are some of the factors that we take in consideration. So for example, if your brain injury occurs somewhere between prior to, say, 7 to 12 years of age, okay, where you have not had a chance to lay down adult behavior. And again, nature nurture, your experience from the environment actually helps your brain develop as you're exposed. So persons who are injured before that tend to have more problems with learning new things because the tools that your brain established to learn and to over time becomes impaired. Even though the young brain is more, there's no what we call plasticity, neuroplasticity, it's able to modify and change. Certainly the environmental impact in the ability of the brain to absorb and interpret what's going on in the environment is impaired. So sometimes early injury could affect adult behavior. So clearly that's the case. Now, the older person understand that your brain degenerates at a certain time. By the time you're 90 to 100, only 10% of the brain cells you were born with are still available. So the brain is so efficient that it has many, many copies of everything it learns. So even though one place it's injured, the parts of the brain, one of the parts of the brain called the hippocampus, it's able to call on those stored resources and recreate environments. So that's why even as we get older, even though we lose cells, we're still able to maintain our function. So clearly, if a person that's older, where they've lost a certain amount of neurons, they get injured, you will see early dementia, earlier form of dementia than you would in a younger patient. So clearly, age is a factor. Now, as we as humans go through different phases like menopause, male and female menopause, our hormonal systems change. And certainly that when those hormones aren't active, a disruption of whatever is left will even cause further disruption emotionally. So clearly, as your hormonal system changes, your brain chemistry, your brain physiology changes. An injury on top of that also causes certain more profound long-term and short-term effects.
And if someone with an invisible illness could do one thing a day, what would you suggest that could be?
Well, certainly, when you have an injury, you have to look at your own personal situations and the situations in the environment around you. And clearly, there are issues that you try to perform that would cause you more distress. So what I tell my patients, we have to find the things that makes you feel self-actualized, that will have a positive reinforcement on your recovery. But if you engage in activities and you push yourself to the extent that you continue to experience failures, failures become reinforcing. So what I encourage people with brain injuries to find that one or two things that makes them feel important, make them feel that they're making progress. This is such an important positive feedback in the treatment of brain injury, so important because these patients are experiencing so many negative experiences on a daily basis that they either start avoiding or protecting. And so if we could encourage them by giving them these positive experiences. So if it's going out in nature in the morning time or doing yoga or sitting with a friend, and again, there are many, many activities that have negative effects, like substance abuse. Because sometimes what happens to persons in this situation, they would have had a bad experience every day of feeling depressed and anxious. And they may have just discovered that if they use one of these substances for some moment, they forget their situation. And of course, that's how abuse comes into play. So it's very important that we understand what that person is going through and allow them to have these positive reinforcers.
And you briefly mentioned about how you feel that the brain injuries and concussions can affect mental health. What do you feel can be done to help with the healing of these effects?
I believe that some of the most important contributions that we could make to the mental health aspects of patients is to treat many of the disabling physical symptoms that they're experiencing. If you treat those, many of the mental health issues actually correct themselves. In fact, a lot of times we focus on the mental health issue so much that we forget that there are drivers or triggers that trigger those experiences. So, so for example, if someone has, many persons with brain injury have a kind of a bipolar-like experience where they have these moments of elation and then they go to extreme depression. And many times those are triggered by lack of sleep. And by simply having the patient sleep in a natural way, you could curb those extremes in bipolar symptoms. And yet we focus so much on treating the bipolar symptoms, we forget that sleep dysregulation is a major contributing cause of this condition. So from an approach standpoint, understanding some of these physical symptoms and treating them would ultimately help in the mental health situation. The other thing is not to stigmatize people, and because then that alone causes tremendous problems with self-esteem and a person's ability to function in society. So then you would see a lot of the avoidance and failure to engage, feelings of a lack of self-worth and so forth.
Yes, definitely. The repercussions of the stigma, that's been bypassed as well. People are thinking about how that lack of awareness and understanding is affecting a person's health or who's already struggling, and that could literally be the point that they break, you know. And I really hope that something wonderful comes from this, because you're making just such valid points that probably hadn't even occurred to me. So yeah, thank you. And you mentioned sleep, so I'm guessing that that would be a great pain management and a pain reduction tip. And do you feel there are any more pain reduction remedies that you could recommend, please?
Well, one of the things I do early in my practice is to get the patient to feel like they're normal. And to do this, if they're having pain, I want to get rid of their pain. And sometimes in our practice, we use a lot of nerve blocks or blocking the pain through injectable treatment modalities. And there's a whole field of pain management that has evolved. So for example, some of them might have a fractured rib, and that's really painful. And in many cases, the doctors don't take the time to help that patient by giving them a block to the nerves around the ribs. And it's a simple procedure. Or headaches. One of the problems I see very often is there's a condition called trigeminal neuralgia, trigeminal cephalgia. There's a nerve that comes up above your eyebrow right there on either side. And as you know, one of the most common places to get hit is in the front of your head after an injury. I'll tell you, in a high percentage of the time, that nerve is injured. And it's a major cause of headaches. And even into the long term, I have great successes. And in fact, I've published some articles on this, where you would block that nerve with a little bit of anesthetic and some small amount of steroids. and the patient would experience instant relief in their headaches. I have patients with headaches that, similar to migraines, that are there for months and months on end, and they come into my clinic, I block the headaches, and they feel totally different. Managing vertigo and dizziness, those are some of the worst symptoms. You know, you go out in public and you feel like you're falling, there's motion all the time, you feel like you're moving, you feel the world's moving. That's an important symptom to treat, and we use medication and other therapeutic modalities to treat. There's a condition called convergence disorder, and it's simply diagnosed by asking the patient to put their hand in front and move close to them. And as the hand gets closer, they get headaches, they see double, they have trouble, and it's called a convergence. The two eyes can converge on an object. So for example, they're driving at nights, and the lights from a car in incoming traffic would make them feel very sick and cause headaches and dizziness, and sometimes even get into accidents. Again, that's a disorder that we could treat with therapy because the brain is trying to interpret what's going on and it can't do it. So it's having a negative experience. So it's compensating by causing the person to experience these symptoms. So again, by knowing these signs and symptoms, when they occur, what are the precipitating events that cause them, you can help a patient in tremendous ways. And so those are my tips. When I talk to clinicians, when I lecture, when I talk to families, we try to come up with some practical solutions so that they could feel good. They can have a positive experience. Once a patient starts feeling good, they start sleeping, you start controlling how they feel about in the outside world, how they handle motion in the community, their headaches, their pain in the other parts of the body, they come alive. And then you could better treat the cognitive parts. Because they're not as concerned that they're having memory problems. They're more concerned that they can't sleep, and they're having pain, and they feel nervous and anxious. But if you don't treat those, then you're not going to be able to get to the cognitive sides. And again, a lot of times, even the neuropsychologists, they focus on testing. And if you're testing a patient that can't read or can't see or is having a headache, you'll come up with really bad results. It doesn't mean that they're that impaired. One must be able to fully understand what they're dealing with in terms of the physical signs and symptoms. So I have an order. I treat first the physical symptoms, and then I go to the adaptive neurobehavioral symptoms like the panic attacks, the OCD, all of those, and then I go to the cognitive. Because if you treat the other two, then of course the cognitive functions might even get better on their own.
It's a very complicated process, isn't it?
Absolutely. Lots of years of seeing lots of patients and reading and studying the medical literature, and also learning from your colleagues and your patients.
And do you find that conditions and new symptoms can manifest throughout recovery? If so, what causes this, and what can be done to manage new symptoms on symptoms while working through recovery and rehabilitation?
So that's a very important point that you just brought in terms of a question, because even clinicians who are treating brain injury have a philosophy that once you're better, you're better. But many patients actually develop new symptoms. Sometimes I see patients with discharge from the emergency room or from the hospital after trauma, and they go out and they're fine. And 3-4 weeks later on, they come to my clinic with the worst headaches, the worst dizziness, the worst vertigo. But what's happened, they go back to their lives and they become exposed to environments that actually trigger the brain to react in those ways. And so the fact is that there are vulnerabilities that clearly exist that may be suppressed at the time, but manifest themselves later on. And in fact, some of those could manifest themselves even years after an injury. And again, in the medical legal community, there's this concept that could never happen. So so these are all myths that have been perpetuated over the years about brain injury, and we have to dispel many of those myths. So clearly, we have a long task ahead of us, and I have to tell you, I admire what you're doing in terms of providing a voice for people that don't have a voice.
Oh, thank you. You're going to make me emotional. Absolutely. I mean, yeah, just touching back on that question. So, oh, your baby. I was going to say something. I was going to elaborate some. Oh yeah. So, for example, do you feel like symptoms can be a life force, and it's almost like when you're trying to rehabilitate with a symptom or recover, that it's almost like the antibody of, or like a virus kicking in. I don't know, this is just how I kind of analyze it. If there's a new symptom, and it's like its own life force, and it will manifest in another way because you've figured out a way to heal that part of yourself. So I just don't know how that kind of operates. I don't know if I explained that very well.
Actually, you did quite well there. You know,
Thank you.
there's something in the nervous system that I have observed over the years, and it's been spoken about by many neuropsychologists and scientists. And it's the way the brain learns. And how you've just said it actually is really appropriate in that sense. The brain learns through something called associate learning. It's one of the most powerful forms of learning that exists in nature. So it's associate something with another. And there's a guy named Pavlov who did some experiments. Many of your viewers might have heard of Pavlov's dogs. And what he did was he had two groups of dogs. One that, he rang a bell, and when the dogs would come, he would give the dogs food. And then the dogs will start salivating, producing saliva. Then there's another group where he'll ring the bell and didn't give them food. Okay, they wouldn't salivate. Now, when you take the food from the dogs that salivate and you don't feed them anymore, but you now ring the bell, every time they hear the bell, they continue to produce saliva, whether or not the food was there. That's what happens to the brain when it's injured. It learns from that trigger, and it starts behaving accordingly, and anytime that trigger comes along, call that trigger foods, the brain starts salivating and starts behaving in ways that you may not want to. So now, if you want to stop the dog from salivating after that bell rings, you can't, because the nervous system has developed a pathway to respond automatically when such happens. That's what happens to people with brain injury, is that they can't shift away from, once that pathway is learned or developed, it becomes next to impossible to stop. And that's why when you have panic attacks and OCD and those conditions, bipolar symptoms, they're almost impossible to stop. And so people end up living their entire lives with these conditions. So again, my concept, which I talked about in the book, is early intervention in the treatment and management of brain injury is to prevent that process of associate learning from taking place. Because once it happens, it's hard to stop. This is what happens with people with addiction. This associate learning occurs. And once it takes place, it's hard to reverse and fix. So this is a major concept, in my opinion, from a theoretical standpoint in understanding and treating people with brain injury, is to, once you understand the nature of associate learning, you could learn how to treat persons with brain injury.
And I'm guessing this is where neuroplasticity comes into play, and you can retrain your thinking, retrain your thought process on a subconscious level, and help yourself to transform. Do you think that if you become aware on a conscious level, or even feel like you are on a subconscious level, that can just prevent anything moving? Or I know it's not as simple as that, but can that alter the if I say the life force of the condition, could that alter it, but it can still exist?
Yes, and again, when we look at, I always like to talk about mind-body relationships. What you don't realize is how much your outside environment influence how your brain behaves. It's fascinating, your immune system, how your body copes with things. We see there are strong physiological connections. Now, people talking about even your gut, your intestine and its relationships to the brain and how inflammatory processes occur. All of those factor in terms of your body's ability to improve and heal itself. So neuroplasticity as a concept in the process is very critically important in recovery. And neuroplasticity takes many different forms. It's not that when injury occurs, one of the first and most important process is to what we call prevent the brain from, we call it neuroprotection. That's the first step. When someone comes in with a brain injury, we want to protect the brain from further injury. First, you want to prevent them from getting injury, and once they're injured, you want to prevent the injury from getting worse. And basically, we are racing against time to reduce the chances of brain cells dying, connections being disrupted. And if we can do that, then that's your first step in neuroplasticity. After we've actually tried to preserve the brain, now we're left with how do we get what's left to function optimally. And again, neuroplasticity is also involved in this process because now neurons and nerve cells have to reconnect. In some cases, we have to grow new nerve cells in order to establish function. So that is the process that the brain goes through to recover.
And I'd love to learn more about your book, Concussion, Traumatic Brain Injury from Head to Tail, A Silent Epidemic. That is quite a title there. I'm very intrigued. May you tell us a little bit more about your book, please?
Well, thinking about I've already talked about this whole hierarchical organization of the brain, and I've introduced this whole method of treatment called the BHET Method, Brain Hierarchical Evaluation and Treatment Methodology. And that is, if you understand how the brain is structured, and the book, the last part of the title, From Head to Tail, from the most sophisticated to the most simple, then you could exercise a multi-dimensional approach to both understanding the nature of the injury and classifying it properly, understanding the triggers, and now having a methodology to treat at the different stages or different levels. And again, that's the reason for writing this book, is to be able to explain these very complicated concepts using patient stories and using illustrations like the computer, like how a car works, so that persons could have a way of understanding how the brain works. This is one of the most difficult subjects to explain. And like I said when we started, it's the most complicated disease of the most complicated organ system. So most people, when they hear brain or brain injury, they shut down, they close out, and it's like, this is too complicated, I can't understand this. And what I did in my book is to try to bring this to a level that both a professional and the man in the street could understand. And certainly, having some knowledge in sciences could help, but I try to use illustrations to explain how the brain works, how the brain is injured, and how the brain recovers.
So you wrote this book with like the patient and the medical profession in mind?
Absolutely, both. And again, when you think about it, when you look at most books that are on the market about brain injury, they either address the family side of what's happening, or they're a textbook. that's so complicated that even doctors have a hard time understanding. So there is a point where the clinician and the patient's family and society must meet. And that's what I tried to do in the book, is to bring that community together so the stakeholders could understand each other's issues. And until we do that, we're not going to start doing something to make a difference in the brain injury world. We must bring those two communities together. And the idea of this book, using patient stories to illustrate these complicated points so both the patients and the doctors could understand. What I've also tried to do is to help my colleagues learn how to explain complicated issues to their patients, and to help patients understand what doctors and others are going through when they're dealing with these complex subjects. So again, it's a tall order in trying to write a book to that level, but I was determined to do that. And in fact, I had to write this book myself. I couldn't get someone else to write it for me or dictate it. I had to write it, although I had a lot of help in editing and so forth. But it was important that to try and direct the level of this book so it will meet the needs of the people around us, so that it'll have an impact.
And because it's something that only you could explain, like you say, you had to kind of go ahead with that. And is the one thing that you learned about yourself as a medical professional on your journey of writing the book?
I'll tell you this. When you think about your life in terms of what you do for the world and the difference you make, all of us have an impact and make a difference in the world. And sometimes a lot of people don't have a way of trying to understand what that impact is. I feel fortunate that I had the opportunity to study neuroscience. Somebody like myself would really have this opportunity in the world, and not just to study neuroscience, but to treat the amount of patients that I had to treat, and being exposed in an academic environment at the height of my career to both be involved in the policy side from an administrative standpoint, the advocacy side, the treatment side, and to see all the dimensions of this condition up front and center. So I feel, first of all, fortunate that I had this opportunity. And in a lifetime, if there's one contribution I could make, is all the knowledge and the experience I gleaned from that experience to be able to pass that on to generations beyond. And so if we could, in a small way, impact the world, that's what we do. And to me, that's the significance of what this work represents.
And could you tell us a little bit more about Design Neuroscience Centre and where to find you, please?
Well, coming out of the University of Miami, one of the things, and Jackson Memorial Hospital, where I spend most of my years, I also do work at Kendall Regional. It's a trauma center and another rehabilitation center locally. One of the things I've realized is I wanted to maintain this continuum of care, but it was important to develop Design Neuroscience Center as an interdisciplinary system of care for patients. It was impossible for me to do this in these large institutions because they focus on saving the patient's life, but they're not focused on restoration and get them back to the quality that those patients deserve into the long term. So it was important at Design Neuroscience Center to build a team. Here we have 6 neurologists, 1 physical medicine and rehab specialist. We have physical therapists, occupational therapists, speech and language therapists, neuropsychologists, and a team of professionals, including some of the trainees that we have. We try to spend a lot of time training doctors, training psychologists, because we feel that's the one way to give back to the world and to perpetuate these concepts. This whole idea of having a team approach, interdisciplinary team approach, where you could look at the patient holistically and share this whole experience with all of the team members, gives us a kind of advantage in being able to come to the right conclusion and offer the right tools to the patients and their families and society. So clearly, this organization and writing this book has given me an opportunity to spend more time on the advocacy side, working through the DNC organization and helping my team members help others. So we've become a kind of resource at DNC, and we're trying to increase our services to a level that we will help cater to the public in a more general way upon these issues as we could help raise them. And again, the best way to do this, I'll tell you, social media has been a tremendous boost to this movement. And we've only started this a short time ago. My book came out a couple of months ago, and we've started on social media. It's been amazing, the response we're getting, and how people appreciate the services. I mean, if you see my Facebook and other social media, the comments from others, it's really refreshing.
And is your Instagram and Facebook the best way for people to contact you, or is it through the website?
All of the above. The website is simple, concussiontbi.com. And of course, the Facebook and so on, if you check my name out online, it'll come up, Kester Ned. Also, our book is available on Amazon and through various outlets. So.
And is there anything else that you would like to add, Dr. Ned?
Well, first, I want to thank you so much for this opportunity. You're an amazing advocate, and the work you're doing is just inspiring to me, and I assume to the world. And certainly, I'm so happy that even though we're on two sides of the ocean, we've had this opportunity to connect in the way we've had. And I trust and hope that the people out there that will get to view this would get a sense of hope in whatever they're going through. So certainly, we both are providing a voice to people who don't have a voice. And I thank you for the opportunity.
Absolutely, I thank you. That was so lovely of you to say. Thank you. I really appreciate that. And I was going to ask, because we're part of Warriors of the World, and we ask a warrior wish. So if you could have one wish, what may that be?
Well, my wish would be that we could educate the world about the true impact of brain injury. It'll make a huge difference. And
together, bringing our minds together, our brains together, hey, no pun intended.
Yes.
That's the way we make this happen, across the oceans and connecting. And it's been so fantastic to talk to you, and I just can't wait to look back at the video and, make sure that I can take more of this information in, because, it's very intricate details and a lot of food for thought. So thank you so much, Dr. Kester Ned. It's been an absolute pleasure to talk to you.
And so it has been on my side. Thank you. And yes, thank you so much.
And keep us posted with the book. And
we will.
if you would like to send me any links with your articles, I would love to read. And I'm going to check out more about your book as well. So I did have a look at the preview. You've got the 2-page preview. So yeah, it looks amazing. So keep us posted with everything, and I'll speak to you very soon.
Thank you.
Thank you very much. Goodbye from England.
Oh, goodbye.
Bye, Miami.
Speak Miami, to you soon. Florida. Sure, yeah. Goodbye.
Well, you never know. We might have a cup of tea next time if I pop over there.
Absolutely. We look forward to that.
Yes, absolutely. I'll speak to you soon. Thank you.
See you soon.
Bye.
Thank
Bye.
you. Bye.